Hi guys, this is Dr. Pawan and welcome back to Surgery 101. So Surgery 101 is a series which I have started, which basically means that learning surgery with me one-on-one. Okay, so this is episode 2 of this particular series. Let us talk about this. What are we doing in this particular series? So we are discussing a couple of MCQs. Yes, again, as the series progresses, we will discuss images and other kind of questions as well. But yeah, for now, I have a couple of MCQs with you. For you, let us kind of see how exactly it goes. The first question which I have for you guys is T-tube cholangiography. So I hope you understand that there is a T-tube cholangiography which is done. What I'm trying to ask you, it is done on which post-operative day? So first of all, where do you do this T-tube cholangiography, or where do you use a T-tube if at all you are going for a CBD exploration? After CBD exploration, you use a T-tube. Okay, after a CBD exploration, you use a T-tube. What I'm trying to ask you, this T-tube cholangiography is done on which post-operative day? So T-tube cholangiography is done on post-operative day 8. Okay, now let me just explain you about this particular stuff. Now, it doesn't matter whether you are going in for a open or a laparoscopic CBD exploration. So if at all you go in for an open or laparoscopic CBD exploration, what you need to understand, if at all you are going in for an open or a laparoscopic CBD exploration, you have to kind of close this particular thing on T-tube. Okay, so you have to close this particular stuff on the T-tube. So yes, you put a T-tube over here. What do you perform along with the T-tube? You go in for a T-tube cholangiography. So what you do, you go in for a T-tube cholangiography. Now, what you need to understand is that why do you want to go in for a T-tube cholangiography? Okay, why are you keeping this T-tube for the first place? So the reason for keeping the T-tube is, okay, it acts like a stent. It acts like a stent. And at the same time, this T-tube is also helping us to know whether there is any retained stone is present or not. Okay, so it is trying to tell you whether there is any retained stone which is kind of present or not. And to kind of know this, what you do, you perform a T-tube cholangiography. So what do you perform? You perform a T-tube cholangiography, and you perform this on the post-operative day 8. On post-operative day 8, you basically perform a T-tube cholangiography. When you perform a T-tube cholangiography, what are you basically looking for? You're looking for any retained stone. If at all any retained stone is absent, is not present, okay, there is no retained stone. So there is no retained stone. What you need to do, you need to remove the T-tube. You remove the T-tube on post-operative day 10 to 12. You remove the T-tube on the post-operative day 10 to 12. But if at all the retained stone is present, if at all it is present, what you need to do, you keep T-tube for 4 to 6 weeks. You keep T-tube for 4 to 6 weeks. Why do you want to keep the T-tube for 4 to 6 weeks? Because you want it for the maturation of the tract. For maturation of the tract. So yes, you are waiting for the maturation of the tract, and once the tract is matured, you go in for a choledocoscopy, and you remove the stone. Okay, so this is how you basically manage a patient of if at all you're going in for an open or a laparoscopic CBD exploration. What you need to understand, you go in for a T-tube cholangio. So you put a T-tube. Why do you want to put a T-tube? You want to put a T-tube because it will act like a stent, and it will kind of it will basically you want to look for any retained stone which is present or not. Now for the T-tube, what you need to understand, for the T-tube you need to perform a T-tube cholangiography. So you'll perform a T-tube cholangiography on the post-operative day 8. Now when you perform a T-tube cholangiography, what are you looking for? You're looking for any retained stone. If at all there is any retained stone which is kind of present or not. If at all the retained stone is absent, if at all it is not present, what you need to understand, you remove the T-tube on the post-operative day 10 to 12. But if at all the retained stone is present, you have to keep the T-tube for 4 to 6 weeks for maturation of the tract. And if at all this particular tract matures up, later on you can go in for a cholecystoscopy and you can remove the stone. Okay, I hope you are able to understand this point. This is all the function of the T-tube. Now, moving on to the next question, guys. So the next question which I have, which formula is most accurately used for calculating the burns in the children? Whether it is rule of 9, Burkow formula, Lund and Broader chart, or the rule of Palm. Now, let us evaluate it one by one. What is the answer over here? Okay, answer over here is simple. It is Lund and Broader chart. Now, what you need to understand, what about the rule of 9? Let us talk about the rule of 9. The rule of 9. Now, rule of 9 for the children is, it is a bit modified. Okay, so let's talk about the rule of 9. Let's first talk about the rule of 9 for the adults. For the adults, what is the rule of 9? You have like 9% is basically for the face. Then you have 18% for the back and the front. Then you have 9% for the upper limb each. You have 18% for the lower limb each. And then you have 1% for the genitalia. Okay, so what do you have? You have 9% for the face. You have 18% for front and back. So whatever, like chest and back. Then you have 9% each for the upper limb. And then you have 18% each for lower limb. And you have 1% for genitalia. You have 1% for the genitalia. This is what you have. Now, what you need to understand, this is for adults. If I talk about the children, okay, if I talk about the children. So for the children, what you have, there is a modification. Here, the face is getting 18%. Okay, now the front and back is the same. It is 18% each. So that is what is your front and back torso. Then you have 9% each for the upper limb. Okay, then your genitalia is 1%, but your lower limb, it is basically reduced down to 13.5% each. Now, what you need to understand, this is the basic of the rule of 9 for the children. But okay, why this is there? Why this is there? So as if you will notice, your face is getting more percentage as compared to the face of an adult. Why this is there? Because in the children, what you have, the ratio of the face to the body, it is higher. It is higher in the children. But I hope you understand this. There is a 1-year-old child and there is a 10-year-old child. And the ratio of the face to the body is constantly changing. And that is the reason why the rule of 9 is inaccurate to calculate the percentage of burns in children. So rule of 9 is inaccurate to calculate the percentage of burns in children. Inaccurate to calculate percentage of burns in children. Okay, right. Now, what else you need to understand over here? Rule of 9 is inaccurate. Now, that is why what do we have? We have Burkow formula. So, Burkow formula. And you have Lund and Broader chart. So, Burkow formula and the Lund and Broader chart are there. These are the two things which are used to calculate percentage of burns in children. And what you need to understand, out of these two, the Lund and Broader chart, this is kind of better. Okay, this is better suited to calculate the percentage of burns in children. Are you able to understand this point? So yeah, this is what you need to understand regarding the Lund and the Broader chart and all those stuff. Now, lastly, let us talk about the rule of Palm. So there is something which is called as the rule of Palm. Now, what you need to understand, the rule of Palm is 1%. So what do you understand by the 1%? Okay, so if you take the palm of the patient, it is constituting 1%. So just remember, the rule of Palm is basically used to calculate patchy burns. So what do you understand by patchy burns? It means that, let's say there is some part of the upper limb which is affected, some part of the back which is affected, some part of lower limb is affected, but nothing is kind of affected in totality. So that is what is called as a patchy burns, and in these conditions you have to use the rule of palm. Okay, so this is how you calculate the percentage of burns. And yeah, now let's move on to the next question. So there's a patient who is coming to you with a pressure sore and has a non-blanchable erythema without breach in the epidermis. What is the stage of this particular pressure sore? Now here, what is the thing? The patient is having a non-blanchable erythema without breach in the epidermis. So if at all there is a non-blanchable erythema without any breach in the epidermis, it is stage 1. Okay, what is it? It is a stage 1 bed sore. I hope you are able to understand this point. It is a stage 1 bed sore. Now let us talk about this. This is what is a bed sore it looks like. Now, okay, very simple question. I'm sure that you guys know this. What is the most common site of the bed sore? What is the most common site of bed sore? It is not sacrum. Okay, it is ischium. Ischium is the most common site of bed sore, as compared to then there is a greater trochanter followed by the sacrum. Okay, so there is a greater trochanter followed by the sacrum. Now, let us talk about the classification of the bed sore. Classification of bed sore. So to begin with, what do we have? We have the stage 1. So what do we get in the stage 1? In the stage 1, we have a non-blanchable palpable erythema. Okay, so a non-blanchable erythema, but there is no breach in epidermis. Okay, so there is a non-blanchable erythema, but there is no breach in the epidermis. This is what is your stage 1. Then you have stage 2. You have stage 2. In the stage 2, what do you have? Here you have a partial thickness skin loss. A partial thickness loss of epidermis and dermis. So here you have a partial thickness loss of the epidermis and dermis. Okay, then what do you have? You have stage 3. What is the stage 3? So in the stage 3, what do you have? You have a kind of epidermis plus the dermis is involved. But fascia is not breached. Okay, so fascia is not breached. Are you able to understand this point? Here the epidermis and the dermis is involved, but the fascia has not yet been breached. And finally, what you have? You have a stage 4. You have a stage 4. What is the stage 4? So here it is going deeper to the fascia. So even the fascia is breached and there is involvement of an underlying muscle and bones are involved. I hope you get this point. So here the fascia has been breached and the underlying muscles and the bones are kind of involved. Okay, so this is about the classification of the bed sore, which you need to understand. Here, please understand, it is a non-blanchable erythema. Now, just one particular stuff in burns. In burns also there is a stage 1 where there is an erythema. But what you need to appreciate is this particular erythema is a blanchable. Okay, it is a blanchable erythema. Please understand this point. So this is a basic difference which you have in the burns. Again, there is stage 1 where you have an erythema, but that is a blanchable erythema. But in the bed sore you have a non-blanchable erythema. Okay, I hope you have understood this point. Now moving on, feeder artery for the LD flap. Okay, LD is Latissimus dorsi flap. Latissimus dorsi flap is what? Is it a thoracodorsal artery, circumflex-scapular artery, suprascapular artery, or the inferior pectoral artery? Now answer to this is a thoracodorsal artery. Now let us evaluate what is an LD flap. So it is a flap. Okay, what is a flap? Okay, I hope everybody understands that a flap means that it is basically having its own blood supply. Okay, it carries its own blood supply. It carries its own blood supply. This is what is a flap. Now what you need to understand, this is your latissimus dorsi muscle. Okay, this is what is your latissimus dorsi muscle, and what you have over here, you have the artery. Okay, so you have a thoracodorsal artery which is present over here. So there is a thoracodorsal artery which is basically present on the latissimus dorsi muscle, which is basically supplying the latissimus dorsi muscle. So I hope you're able to appreciate that this latissimus dorsi muscle, it can be isolated, it can be rotated, and it can be used as a kind of a flap for the breast reconstruction. So this LD flap can be used for the breast reconstruction. Okay, it can be used for the breast reconstruction. I hope you're able to understand this point. What is this? This is what is your pectoralis major myocutaneous flap, PMMF. Okay, what is this? This is a pectoralis major myocutaneous flap. So here there is a patient with a carcinoma. You operated on this particular patient and you use this pectoralis major muscle. So you use this pectoralis major muscle to fill the defect, and this is post surgery. So post surgery the patient is having this kind of a feature. Now what you need to appreciate over here is that this pectoralis major myocutaneous flap, PMMF flap, this is your pectoralis major myocutaneous flap. This is basically based on your internal mammary artery. So this is what is based on internal mammary artery. So PMMF flap is kind of based on your internal mammary artery. Okay, moving on. What is the most common type of a tracheoesophageal fistula? So is it like a type A, B, C or D? Now it is a pretty simple question. The answer is type C. Now what is tracheoesophageal fistula? Definitely that there is a fistulous communication, that is there is a communication which is involving between the trachea and the esophagus. That is what is a tracheoesophageal fistula. Now there are various types of the tracheoesophageal fistula. Which is the most common type? So type C is the most common type. So what is included in the type C? As you can see here, there is an atresia of the upper part of the esophagus, and the lower part of the esophagus is kind of having a fistulous communication with the trachea. So this is what is your type C tracheoesophageal fistula, that is esophageal atresia with a distal part of the esophagus having a fistulous communication with the trachea. This is what is type C. This is what is the most common type. Now if at all there is a tracheoesophageal fistula, what is going to happen? There's going to be a newborn child. There's going to be a newborn child who is coming to you with the drooling of saliva. So there is drooling of saliva. Along with this, what is happening? That there is cough and there is cyanosis. If at all you pass a nasogastric tube, this nasogastric tube, it may coil in esophagus. So this nasogastric tube, it is kind of coiling in the esophagus. This is what is the basics of your tracheoesophageal fistula. Now if at all you suspect that the patient is suffering from a tracheoesophageal fistula, you may go in for a dye study. Now what you need to understand, the preferred dye or the first dye to be used, the first dye or the preferred dye to be used is this is what is your low molecular weight water soluble contrast. So yeah, the contrast which is kind of preferred is low molecular weight water soluble. This is what is the preferred one. But if at all they ask you the best one, okay, but if at all let's say you use this low molecular weight water soluble contrast and is not able to kind of diagnose it, so what is the best dye or a best contrast which is used. So what is the best dye which is used? The best dye which is used is your barium. So even though the barium has a kind of propensity to cause your chemical pneumonitis, okay, it has a propensity to cause your chemical pneumonitis, still barium is the preferred dye to be used, or like it is the best dye which you can use, because it can diagnose most of your tracheoesophageal fistula. Now lastly, if they ask you what should be the investigation of choice for your H type of fistula, so what is an investigation of choice for your H type of fistula? What is the answer over here? It is tracheobronchoscopy. What is the answer? It is tracheobronchoscopy. Tracheobronchoscopy, guys. Okay, you have to go in for a tracheobronchoscopy. That is what is an investigation of choice for your H type of the fistula. Okay, I hope you understand this point. Now let's talk about the kind of a treatment. So treatment is basically surgery, but whether you should go in for an immediate surgery or you first need to resuscitate the patient, this is what you get by a Watterson criteria. So this is what is a criteria which you use. So here, if at all, as you can see, the weight of the kind of a newborn child is more than 2.5 kgs, you can go in for the surgery immediately. But if at all the weight is kind of less, that is less than 1800 grams, or the patient is having pneumonia or some congenital anomaly, you have to kind of go in for a stage repair. You first have to resuscitate the patient, you have to maintain the respiratory status of the patient, and then you can kind of go in for a surgical correction. Okay, so this is all about tracheoesophageal fistula, which you need to understand. Now let us move on to the next question. Which of the following is true about a chronic SDH? So you have a chronic SDH. Now, which of these following statements is true? Bleeding is mostly arterial in nature, always requires a craniotomy, even a trivial injury can cause this particular thing, or none of the above. Answer is definitely C. Now let us first understand what is SDH. What is SDH? It is subdural hemorrhage. SDH stands for your subdural hemorrhage. Now what you need to understand over here, what you need to understand in the SDH, that there is, what is happening in the SDH, that there is a blood accumulating between dura mater and arachnoid matter. So what you actually have is, you have a cranial cavity like this, and inside the cranial cavity what you have? You have the brain. You have a brain parenchyma over it. And what you have? You have the bridging veins. So there are bridging veins which are present. Now if at all there is movement of this, okay, so in the old people what is happening? In the old people there is cerebral atrophy. So in the old people there is a brain atrophy. So if at all there is a brain atrophy which is happening in the old people, what is going to happen? This brain is going to move inside the cranial cavity, and because of this there can be a shear stress on the bridging veins. Because of this they can tear, and because of this there can be a blood accumulation. So as you can see, this is a bridging veins. So whatever the blood is accumulated, it is venous blood. Okay, it is a venous blood, it is not an arterial blood. I hope you understand this point. It is a venous blood which you have in over here. Now so this makes that this particular thing is wrong. Mostly arterial in nature. No, it is venous in nature. Now what you need to understand is, because it is occurring in the old people who are having this particular brain atrophy, and the brain is kind of hypermobile inside the cranial cavity, even a trivial trauma, what do you understand by a trivial trauma? A slight trauma. Even a slight trauma can cause bleeding. So this is what is actually true. Even a trivial trauma can cause this particular bleeding. Now, whenever this occurs, whenever your patient comes to you with a head injury, okay, what is the investigation of choice? The investigation of choice is a non-contrast CT scan. But what you need to understand here, if you perform a non-contrast CT scan, if at all you perform a non-contrast CT scan, you are going to get a heterogeneous lesion. Heterogeneous lesion, and sometimes it is difficult to kind of distinguish, and that is why over here, investigation of choice for the chronic SDH, for the chronic subdural hemorrhage, the answer is MRI. What is the investigation of choice? It is an MRI. MRI is the investigation of choice for the chronic SDH. So as you can understand, the SDH can be divided into acute, subacute, and chronic. So acute is usually presenting to you within 3 days. Within 3 days, if at all the patient is coming to you, this is what is an acute. What about the chronic? If at all the patient is coming to you after 21 days from the trauma. So trauma occurred, and after 21 days, the patient is coming to you with the bleeding. This is what is your chronic SDH. Okay. I hope you understand this point. Chronic SDH, bleeding occurring after, like patient presenting to you after 21 days from the time of the trauma. Now, for chronic SDH, lastly, let's talk about the treatment for the chronic SDH. Usually, it can happen with burr hole, a burr hole. Okay, usually it can happen with a burr hole, but what you need to understand, if it fails, then you can go in for a craniotomy. If it fails, then you have to go in for a craniotomy. Do you understand this particular point? So yes, this is all about the episode 2, which I wish to talk to you about. I hope that you gained some value out of it. Thank you so much for attending it so patiently. Thank you so much. And lastly, guys, I just want to tell you that, you know what, I am Dr. Pawan, and I am basically an educator of surgery on Unacademy platform. Now, I'm sure that you guys are aware of this. Now, this is a platform which is basically providing you with lots and lots of videos for your NEET PG examination. And if at all you go and explore our Plus platform, there are many structured courses, and they are absolutely directed towards your upcoming NEET exams and to exams to come forward. At the same time, recently Unacademy has teamed up with Prep Ladder. So you can even have a combination of the subscription of the Prep Ladder as well as Unacademy together as in our iconic subscription. You can also have a look at it if at all you are remotely interested into it. That's it, guys. And if at all you wish to kind of take any of these particular subscriptions, you can consider using the promo code surgery101. If at all you use this, you will get around 10% off on whatever the subscription which you take. Okay, that's it. I hope you enjoyed this particular session. See you around. See you in the next session. Thank you so much. Have a great day. Happy studying.